For everyone with an interest in MASH, or more broadly, steatotic liver disease, Surf's Up, Season 5, Episode 10 of Surfing the MASH Tsunami. Our check back with our good friend Tim Jobson from Predictive Health Intelligence to see what he's learned and can teach us from the past year starts now.
This week on Surfing the MASH Tsunami.
There is an urgency with the way this condition, steatotic liver disease, is growing and how it's developing. We can't wait for people to come through the system. We need to go back into the systems and find the people who we need to get into care. And we need to develop the pathways that go with that.
Start with the drugs currently available. Does that change anything, except for the fact that you can motivate people to come in more readily once you identify them?
Yeah, definitely around motivation. Also around motivating clinicians. Historically, we lived through an era of quite a lot of nihilism about fatty liver. So yes, when you're treaters, you're going to get people much more enthusiastic.
I believe asking the question of screening for liver health to protect and locate 1 in 3 adults that have bigger problems and metabolic disease is probably a more cost-effective argument than saying just looking for liver disease, less than 2% of them may all-cause mortality.
Patients don't want their data shared with commercial entities and pharmaceutical companies and Google and the like. They do want their data shared for the purposes of making them stay well. We've reached out to over 300 patients and nobody said, oh, where did you get my data from? How did you find that?
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guest, Predictive Health Intelligence co-founder and director Dr. Tim Jobson, as they discuss what the Predictive Health Intelligence team has learned in the past year and how changes to their model can inform the ongoing discussion on how to identify MASH patients. This week on Surfing the MASH Tsunami.
Remember to stay tuned after this episode for this week's question of the week.
So when we last left our heroes last week, I told you my good news was that I'd had my bank account hacked, but it was okay. They never got the money out. Here's a shock. The bank didn't exactly level with me on this. So I've spent much of my last week trying to recover the funds that were in our meager funds that were in our Surfing the MASH Tsunami bank account. But now we've been successful at doing that. In the interim, there's been another successful conference last weekend in Arizona from Chronic Liver Disease Foundation. And fortunate enough to have Louise with me today and also our friend Tim Jobson from Predictive Health. Louise, how are you doing this evening?
I'm very well, thank you very much. Enjoying being in the one place for a couple of weeks. So it's nice. And it's nice to see Tim.
So you don't leave for Australia till when?
The end of the month. So around about the 27th, 28th.
Not bad at all. And Tim, how are you this evening?
Yeah, I'm good. I'm great. Thank you.
I should tell our audience who's never going to get to see this that this is the least formally dressed episode we may ever have put together. I'm in a t-shirt, Tim's in a hoodie, and Louise is half in the dark. So if you don't see any pictures posted as we promote this week, you'll know the reason why. On the other hand, Tim looks good in a rugged kind of way, and Louise looks slightly mysterious in the dark. So if we could get rid of the pictures of me, I think we'd be okay. With that, why don't we just get started and go straight to Groundbreaker? It's one good thing that's happened personally or professionally in the last week. Brave one, go first.
Oh, I'll jump in, not to put the pressure on Tim straight off. I suppose for me, we've now officially announced the EASL Congress 2024, and myself and Laura Trucco will be doing the Skills Learning Centre on the liver elastography for myself, because I don't use the spleen elastography. I don't have the need for that. So come and join us. Come and register for the skills sessions and come and have some tricks and tips of the trade and a bit of fun and entertainment in those sessions. So I think we've got 3 of those sessions because I'm doing 2 sessions for somebody else on a different area.
So I will try to slide by and catch at least one of them.
Oh, yeah, test the skill.
Yeah, I have no skill in this area. I mean, I will go from total novice to rank beginner, but that might be at least a step in the right direction. And Tim, how are you? What do you have this week?
Yeah, so I'm not going to stick to one. First off, on a personal level, I won't go into detail, but my children continue to, even though they're all grown up now, continue to surprise me and do excellent things, and some really impressive stuff from them this week. From a professional side, we've been shortlisted for 2 Health Service Journal Awards in the digital space. So that's upcoming in June. And we're going to have to rush back from EASL to go to that event and see how well we did in reality. So see how we get on.
So we will only get to celebrate with you prospectively and try not to jinx few at the same time, huh?
That's the one. We'll make a splash if we win one of these awards. It'd be great.
It'd be great news.
Yeah,
I like it. It'll work.
That'd be awesome.
Okay. That would be fantastic. And on this front, I want to thank our audience because, well, we'll talk about this a little bit in the business report, but listenership continues to grow again. We were in 3 different countries last week on the top 250, not top 250 medical, which is kind of easy, but top 250 health and wellness, which is a tougher group. And one of those was France, which is always nice when it's a larger country, not to belittle Eastern Europe and Asia, where most of these high results come from, but always nice to see a country that we don't usually see on that list. On a personal front, it was actually 75 degrees here yesterday, Fahrenheit, not Celsius, 75 Celsius, and we'd all obviously roast, which was just a delightful weather. And the first reminder we've had that it's actually spring. Up until then, it's been rainy and never getting above 10 degrees Celsius, 50
You're
Fahrenheit.
starting
So it
to
was a good
sound
day to have.
British. We talk about the weather. It's a national pastime. You're becoming more English all of the time.
It's doing what it always does here. It's just raining. That's all it ever does here. It's just raining.
I hear that. Well, I guess then my other thing, of course, is that although the last time I talked about how well Tottenham was doing on this podcast, they immediately went to Chelsea, lost 3 players for 2 months, and went in a horrible tailspin. But we're hopeful. Spurs fans are hopeful. Let's just put it that way, that we might make it to the Champions League, even if it's only a 14 British seating. We're favored to do that right now. All right, so with that, just to set this up, we had Tim with us last, I guess, about 14 months ago, maybe January 23. And I think it was season 4, episode 5, for those who want to go back and look, and was talking at that point in time about some of their research and some of their techniques. And what we found intriguing then was and continue to, is the idea that as we need to do a better job of identifying and screening patients cost effectively, that the easiest way to do that is to find ways to use the data that are readily available to us in electronic health records and things like that, which is really when I think of predictive health, that's what I think of you folks as being about. This came up, I guess, in our episode last week when talking about NITs and the idea that first-line screening over time, Jorn made the suggestion, might evolve to be that kind of thing. So with that as a backdrop, I thought we would take a break in our month of Resdivra is Here coverage and step back and dive into that issue in a little bit more detail with one of the people we believe knows the best about it and has done a great job of educating our people in the past. Okay, Tim, I'm done with compliments. Let's just take a couple of minutes and fill us in a little bit on what you've been up to, what the company's been up to, and some of the things you've been working on that pertain to that question. Your floor.
Thank you, Roger. So going back to where we were about 15 months ago, we had developed our case finding solution, grant funded as part of a research project funded by National Institute of Health and Care Research in the UK, and developed a system that could really quickly and simply and effectively analyze a huge amount of data, so existing biomarkers, existing blood tests for our patient population. And what's kind of unique is that we're putting that data into the hands of the frontline clinician to go and seek out the cohorts of patients that they know they want to see, they know there's a problem, and they can find them and then get on and treat them. And that's what we were doing, and we're presenting some early data. Since then, things have gone really well. It's quite timely, this particular opportunity to talk about it, because we just literally come to the end of our period of research funded by EHR. We've got another big grant that's come in from Innovate UK, and we're moving forward with that one as well to further develop population health screening. And I maybe talk about that later, because I think that is going to be really fundamental going forward. But in the last 15 months, we've further developed the solution, the technology. It's quicker, it's slicker, it does better things now, so that's fantastic. And starting to really understand how powerful it can be to analyze the existing data, and also driving out new use cases. So yeah, this is very much focused on steatotic liver disease today, but there are plenty of other things that we can do as well. So we had looked last time, we presented some data about the power of longitudinal analysis. So if you look at data trends over time in a single patient, you can pull out the higher risk patients. And it's what we do almost invariably as clinicians in clinic in real time. We don't just look at today's results, we look at everything that's been happening to that patient over months, years, and now the data is sitting in systems decades even. What is difficult to do is then do that on the existing data sets and pull out patients who've had a problem and have still got a problem that's been evolving for years. We've cracked that problem. And that's what we were presenting, that persistent abnormalities lead to trouble. And I guess from a liver point of view, we know that already. It's just how do we go and find those patients? I think it's fascinating. So we've got 200 million blood tests in Somerset alone sitting in our system. And these are historic. Nobody's going to be looking at them. So they're literally just of what value in the way we currently look at stuff. So now we can unlock that box and say, actually, there's some really rich information and we can look at trends over time. And I guess that's just where we got to 15 months ago. And we did some really interesting things with that. So firstly, going to DDW last year, we presented some data. Okay, let's look at young adults. What's going on there? Obviously, there won't be as many decades of data, but we can pinpoint people, younger patients, say under the age of 30, who have a signal they're evolving liver disease. That's really critically important. And obviously, a key interest to hepatologists, you have the patients with advanced liver disease. So the second paper we presented there was around people who had a clear signal of cumulative liver damage that's now progressing towards that seriously advanced liver disease of F4 fibrosis and decompensation and so on. So we know that using our system, we can tweak the searches and search out those different cohorts of patients. The other real key thing that we started doing, we know that patients with persistently abnormal liver tests are not always investigated with all the other markers for viral hepatitis and for autoimmune diseases. So that's not kind of new in itself, but the scale of it is quite something. So these are patients we identified who've not had those follow-up investigations but are still abnormal liver tests. And we rapidly identified about 9,000 in our local area, and that equates to 1 million people across the UK who've got abnormal blood tests. Over time, it's not going away. It's a persistent problem. It's not a one-off, but yeah, we can identify them and then start doing further tests and find out what's wrong. So we can't tackle all 9,000 at once, so we tackle the higher risk groups, and we started doing that. And then we're getting some real insights. We are identifying people with Hep C, with Hep B, with autoimmune liver disease, but also most of them have obviously got steatotic liver disease of some form or other, but we can pull out the high risk ones. And that's a great thing. So we're putting people back into care who really do need something done from a liver point of view, but there's also markers, obviously, of their diabetes being out of control or whatever it is. So it's a huge cohort, and we can find the high risk patients within that cohort and drill down. And that we presented some of that data in Boston as well. And then finally, the other bit of work that we've been doing has been around deprivation. So it's very easy. We've mapped deprivation index into our system. We can identify people who live in more deprived areas with liver disease.
More deprived for liver disease, is that a socioeconomic comment? Is that a diet concept? Is it a treatment concept? What are we talking about specifically there?
So what we've done very simply, we've taken postcode, zip code, equivalent in the States, mapped all of those to the known, what we call index of multiple deprivation, which combines socioeconomic data basically into one simple decile. Are you in the best decile or worst decile? And those are the people we can target now. And yes, we need to treat everybody, but we know that those groups who are in more deprived areas need different approaches to clinic, different approaches to outreach and all those things. So that's where we've taken the system. And that we've done quite a lot in the last year.
Okay, so that is a lot. That's a tremendous amount, given the scale of your crew. In fact, that's really remarkably compelling. What have you learned on the way through in terms of either data you've been able to publish or things that you've seen that would inform a global audience that includes, a lot of Americans, a lot of Canadians, a lot of British, a lot of Europeans, but with varying stages of electronic health record data or even basic testing data available to them? Where are the low-lying fruit if one were starting into this, for example?
So I think the biggest insight overall, and it's something I've majored on before, is around the fact that we can look at data over time. So that is really important to have a look at that. The key message is there is a huge amount of information sitting in that big data set. So we think of data in terms of a huge data set. Well, we archive it. What else we do with it? We do research on it. What I'm saying is we go further than that and use the information stored in it to then target people for care and for intervention. There is an urgency with the way this condition, steatotic liver disease, is growing and how it's developing. We can't wait for people to come through the system. Yes, we have to manage the patients who come through the system and do that in real time and do that with the most effective treatments and interventions possible. But I also genuinely believe, from what I've seen, the way to do is we need to go back into the systems and find the people who we need to get into care. And we need to develop the pathways that go with that, because we've got to simply avoid overloading the system. And we've been quite creative locally around how we develop those pathways as well. That's the kind of side effect of now there's quite a few more people out there who need attention. We need to be creative and find new ways of doing that.
So what we've been talking about, among other things in our last couple of episodes here, are exactly those two issues: the importance of sequential testing and the ability to get the right people to the right places. So let's start on the first one. Okay. I hear hear that what you're talking about fundamentally is testing over time, right? Do I understand that correctly?
Yeah, it is about testing over time, but I'd say there's a subtlety is people already had testing over time, but we're not looking at the information in that way. So yes, prospectively, there's a cohort of patients we just need to follow and monitor and test them over time and see which way they're going. That is hugely important in terms of managing these people, and where that happens in the healthcare system, I think that's quite tricky. Does that happen in primary care? Does that happen in secondary care? How do we make that happen? But equally, there's a huge numbers of people who've already had sequential testing over time, and we need to tap into that.
Okay. Louise, go ahead. You have a question or comment for Tim?
It was a comment and a question, I suppose. Tim's absolutely correct on all of those statements. Part of the problem is that we are developing systems like hepatocyte and other disease areas as well, whereby we're trying to find and locate patients early by using their own data that they've given and their tests over time. One of the problems that we encounter regularly is the GDPR restrictions for people's data on how you can use it can actually be very obstructive to health and being able to use your own data to find you in advance or find you at risk. Did you find that a big problem within this, Tim, is the first question I've got. And the second one, with the recent budget announcements here, with £2 billion being allocated into improving the data systems in trusts out of, I think, $3.3 billion that's been allocated for healthcare on that particular point. Do you think that's going to help you? Do you think it's actually going to reach the level that you've got? How do you think that might work? So 2 questions in there.
Yeah, data governance is a thread that's runs through our entire project. We spend a lot of time, a lot of effort on it. It's not of great interest to the general public, but it is actually hugely important for the project. And most of our first year was spent getting all of that sorted out. It will always be there. We will always need to go through all the right processes, get the right approvals, make the right requests and so on, and get those data sharing agreements in place. And that is time consuming. It requires a lot of effort into engaging the wider community, both of clinical community, but of information community, IT, and staying within the rules. So we do have to stay within the, very, very clear regulations around what we can do and what we can't. The patients are really kind of almost the other end of the spectrum. The feedback we've got from our public and patient involvement repeatedly throughout the project has been, look, crack on. This is data that we had these tests for a reason, to find out what's wrong with us. You're a doctor, go and find out what's wrong with us. Use the information that you've got and help us be better, help us stay well, whatever it is we need to do. We're not going to make those challenges go away. And I spend quite a lot of time working with the right people in information governance teams and getting that right and making sure that we do comply with the regulations.
Just on that point, could that be something? Nobody wants to go around the rules that we've currently got, but do we need to add something in whereby patients give consent when they attend their GP initially to say that your results can retrospectively be used to help enhance your care rather than wait to put it in, so that we're actually allowing people to use our data at the beginning?
Yeah, I think it's partly that. I also think it's key about data sharing, though. So one of the key issues around GDPR is who is the data controller? That's the fundamental question everyone has to ask. If the GP is the data controller, well, that means the hospital can't see it. But of course, we have data sharing agreements in place for clinical care. This is an extension of clinical care, and we need to do that. And I think there are a lot of challenges around data sharing. So patients don't want their data shared with commercial entities and pharmaceutical companies and Google and the like. They do want their data shared for the purposes of making them stay well. And I think that's the distinction that we need. And how we get that, is that a permission? Is that a consent at the time? Or is that a kind of overarching principle that we can work towards? And ultimately, maybe even changing legislation about how data is used to keep people well. Because otherwise, it's a massive resource that's just not being used. It's crazy.
So, Tim, a couple thoughts about that. And GDPR is a much different issue on your side of the pond than is on our side of the pond. So I'm going to stay over there with you guys for a minute, and then I'll come back to the States. When you've sought permission, well, are you currently in the process of seeking permission from individuals to go back into their records for health purposes, the kind of thing you just described?
So no, this is done at a sort of macro level with data sharing agreements between the primary data controllers in primary care and the hospital trusts in order that that data is shared. To do that at population level, that's, not where we are at the moment and not required, but we need to have legitimate reasons to be accessing and using the data.
Do you have any sense of what portion of individuals are willing to have their data shared in situations like that, or is that something you've not tackled yet?
So we haven't come across anyone in this entire program, with all the publicity we've done, with the individual patients who've been called into the system. We've reached out in the local health community, my colleagues and myself within the hospital, using the system. We've reached out to over 300 patients, and nobody said, "Oh, where did you get my data from? How did you find that?" Yeah, nobody's challenging that. We've had a lot of publicity with offers. You can opt out of this process. Nobody's opted out. So in general, people don't. In terms of the more national position, there is an option for patients to opt out of their data being shared for research purposes and with other organizations. And the national data opt-out in the UK has triggered about 5% of people opting out. So that's about the number of people who say, no, I don't want my data shared for research purposes alone. But this is different. This is about sharing with a local clinical team for clinical care.
Would it be safe to assume that if 5% are opting out for research purposes, that the percentage that would opt out locally for clinical care would be a lot lower than that? Well, you can't get a lot lower than 5%, but certainly lower than 5%.
We've not come across anybody who's wanted to. And I think once people have it explained, go right back to the beginning of the project with our original public engagement events. The only question we got is, what do you mean you're not doing this already? Of course, you should be looking at we have the blood test, the doctors should be looking at the blood test results, even if it's historic and retrospective. If there's something you need to act on, don't sit on it, don't keep it a secret. Come and give us the treatment we need. That was the response we got. Now, that's a select group, but it's borne out every time.
So the question behind my question, which you just answered without specifically answering it, is that the GDPR question is going to be more about how you request permission than whether you get it.
Yeah, I think that's it in a nutshell.
Right. The first point is that you can get enough data without needing to request permission, that you can identify people from whom you can make that request and say, this is really about you. And then once you do that, in fact, you'll get that. So that's the roadblock.
And it's who has access. So this data isn't going to a commercial company. The data isn't accessible by Predictive Health Intelligence. This is us making the data available to local clinicians, and it's only local clinicians who can then log into their system and say, right, I can now find the patients I need to find. And I think that's really quite key to why the patients are happy with that.
So can you foresee a reason that it would work differently in any of the other major European countries, for example?
I think it would be very similar. I think the rule book is essentially unchanged. So the UK has not moved away from GDPR and all the principles therein. And we haven't tested it out in every jurisdiction, but I genuinely think human nature being what it is, people do want to stay well and trust their doctors to do the right thing with the results of tests they've had done.
That makes sense. I can infer, I guess, that in the states where the GDPR rules are, consumers are not as well protected, patients are not as well protected in the U.S. in some ways as they are elsewhere. I mean, you have HIPAA issues, but it's not exactly the same thing. That health systems that have longitudinal records for individuals would have the capability to do the kind of thing you're talking about tomorrow morning at 9 o'clock if they had the tools in place to do it.
Yeah, that's right.
Okay. What have you learned that you're able or willing to share about the specific items that are most helpful or surprisingly not helpful going in the other direction in actually when doing these kinds of analyses?
So the principle we started right at the beginning was anything that a liver doctor would look at in the liver clinic. So it's a broad range of the relevant blood tests. What we haven't done, and what I think and this is from preliminary work we've done and other data-driven projects I've done, if you code the data, coded data isn't as valuable as factual data. So the result of a blood test on a particular day on a particular patient is a fact. That's subject to a lab error or anything else, but it's basically that's a fact. The moment you start putting interpretation on top of that data, it starts to lose potentially its utility. And that's what I found in other projects that are similarly related to what I'm doing, but it's not as useful. So the interpretation is when you do a search for a patient and you search on the basis of facts known about that patient because you know they're clinically relevant facts and you pull them out. So from that perspective, I think that is really important. Where that takes us, so some of the blood tests probably we don't search on as often, but the whole picture is important because you can integrate a lot of information into a search and find the right people. So I wouldn't exclude anything of the things that we've included. I would just be really cautious as we developed the technology and it is getting faster, it's getting more powerful, we can pull more things in. That principle of sticking to the facts known about a patient are really fundamental, because you can make a true assessment of risk and diagnosis, not relying on something that historically somebody else has put into a system. Maybe they put that information in a hurry, maybe things have changed since. It's what's going on with that patient today. And a really good example.
So what would be an example of an interpretation?
I'll give you an example. So going into a good living example is hepatitis B. Okay, somebody's got a positive test for hepatitis B. If you haven't got all the data, you're left wondering, well, is this an acute case or is this a chronic case? And if it's an acute case, is it going to, or has it already resolved? Just really simple like that. And if you start marking up the patients as they're in that group or group A or group B, you might be right, but you might be wrong. And you're more likely to be wrong if you haven't got all the data. From a hepatology perspective, from a treating liver patient's perspective, if their last service antigen is positive, they either need to repeat to see if it's gone away, or they need to come and see you in clinic because they've got chronic disease. It really is as simple as that. But that's all based on the fact of we've managed to identify the last blood test in a long chain of lots of other blood tests and make our assessment on that one. And that's just an example where that's much easier to find the right patients based on the bloods rather than what somebody might have labeled that patient with incomplete data.
Okay. Yeah, Louise, you're nodding. Go ahead. While I kind of formulate in my mind.
And it all makes perfect sense. The one thing when I was looking through, Tim, do you define different levels for men and women, for example, so that you identify women on lower levels, or do you just have a standardized sort of abnormal range at all? The more we look into health, the more we know men and women are different, things like that, particularly in liver disease and age. Cut off on that?
Yeah, really good question. So when you're setting up a search, we force people to decide, are you searching on men or are you searching on women? That's the kind of first question in the system, because there's sufficient differences that you need to do that. Now, for certain conditions, for viral hepatitis, you kind of merge the two searches at a later stage. But for a lot of things, yes, the sex-specific levels are really important. The second thing we don't do as much as perhaps we maybe envisaged at the beginning, is define normality and abnormality. So for a continuous variable like ALT, it's a relatively meaningless concept. What you need to understand is the risk threshold. And the risk threshold over time is probably much more important than the risk threshold for a single test. And we know that if you ask people what the normal ranges are, they'll give you all sorts of different normal ranges. We know the healthy range is very different from the normal range. And then if you change the normal range, what are you actually saying? Because mostly it isn't that your units have changed or assays changed. It's because the population has changed. Well, if the population is getting more unhealthy, it does not make sense to change your normal range to bring them all back into normality. So that's why it's really the system we designed means that the end user can say, this is my threshold of interest. I'm interested in everybody who's got an ALT over 19 might be their question. And that's going to be a very big number. If you're looking for something more specific, then you can narrow it down. And the same when it comes to age, yes, very much. The system automatically calculates FIB4s for you. It makes it easy to put out people with high FIB4s or trending up FIB4s as well. But we know that that's an age-specific marker, and over the age of 65, it's not a very useful marker. You can set the age threshold and tailor your search to the group you're looking at. And that's the beauty of the system. That's all in the hands of the end user. We're not saying this is how you need to use it. This is the button you need to press to get a list of patients. This is developing a system that the end user clinician say, I know what I'm looking for, and it's this group.
I did have another question on a comment that you made earlier. The younger patients. Do you get a feel with this system that we're seeing more people presented to GPs at a younger age because they're unhealthy? Or do you think it's just the ability of the system to pick out those with more liver issues at an earlier point? Because, of course, we know childhood obesity has grown, or MASLD and MASH in younger people is rising, type 2 diabetes we now see at younger ages. And we know that bad teeth in your deprived areas are really high, which suggests diet is really poor, linking to deprivation, but picking out those patients and following them longitudinally, things like that. So are we getting a real sense from what you were saying earlier that we're seeing more people present younger because they're just unhealthy? Or is that not something you can draw out?
No, it's really fascinating. So I think we haven't got enough data yet to understand what's actually happening here. We know the prevalence is going up. We know the prevalence of advanced liver disease, so F2, F3 fibrosis is going up in those younger cohorts. And we are starting to see that we can find them. Therefore, by definition, they are engaging in healthcare. They are having repeat blood tests. They are being seen by the GP. I think there's some really interesting research questions which I can't answer today, which we can go back and have a think about, or other people might do, about engagement and understanding by their clinicians. So do all clinicians who interact with these patients understand they could be developing advanced liver disease before the age of 30 through fatty liver disease? Now, if you'd asked me 20 years ago, I'd said, of course not. That's not going to be happening. If you ask me now, I go, absolutely, yeah, that is seriously happening. So that's a change in perspective in a changing world. How many people have changed their perspective and are seeing that? But it's part of our upcoming research projects that we're embarking on now, trying to say, okay, we've got to be really careful because we've got to find these people whilst they're still young to avoid problems a decade down the line. And it's shifting that focus to younger groups. So no, we don't have all the answers, but yeah, it's absolutely incredibly important question. Because if you compare alcohol-related liver disease and metabolic steatotic liver disease, we still see later presentation in the latter, earlier presentation in alcohol, because people haven't developed advanced liver disease from steatotic liver disease until later life, and often too late for a transplant and so on. My prediction, guesswork maybe, informed guesswork, that's going to change. I think we're going to see more advanced, earlier presentations of end-stage steatotic liver disease, and then we're going to really wish that we'd done something about it in 2024, because in 2034, when we're looking at this, it's going to be too late, so we need to be doing it now. And there's a real urgency around that.
Yeah, no, I agree with you. And we're fairly good on this at predicting what's going to happen in the future with serving the MASH crystal ball. So we'll take you that one in 10 years' time. And
it's all ugly. So, without intervention, it's all ugly. So, yeah, go ahead, Tim.
Bringing it together, there's a long-term problem that comes with a real urgency now. Yeah, it's like a tree takes 100 years to grow. So when do we need to plant it? We need to get planting it right now, this afternoon. It's that old quote. The new treatments coming through, we need to know how to target those and target those to the right people now. Yeah, there's an urgency around that. I know the first approvals are only just there, but there's going to be a lot of additional approvals coming through for steatotic liver disease, and we need to get those to the right patients where they have the biggest impact. The viral hepatitis, we're saying we're going to eliminate or control viral hepatitis by whatever the latest target date. There's a real urgency to get on and find the people that are out there that are still missing from care. And that's what really brings some of the urgency to this.
So let me break viral hepatitis and younger steatotic patients into two groups, MASLD patients, if you want, to two groups, okay? What is the challenge with the viral hepatitis patients that you can't find? And how is that similar to and different from the challenges we have right now with younger patients at earlier stages of MASLD who in a decade are going to be a real mess? I have some assumptions, but I'd rather not state them. I'd rather ask the question and then hear what you have to say and then ask questions after that.
Yeah, so the viral hepatitis case finding, and you've got two problems. You have the sort of case finding and then you have the engagement and getting into treatment, and that can be really challenging, probably more challenging than viral hepatitis than it is in steatotic liver disease. You can persuade somebody they're metabolically unhealthy, and provided you've got something to offer them, I think you can engage them in care more easily than some of the harder to reach groups who are more socially deprived, more likely to be homeless, all these things. So we know there's an engagement problem. I think with the viral hepatitis, what we need to I think one of the challenges is, though, the understanding in general of how many are lost in the system. Number one, they've got the markers. We know we should be seeing them. We've lost track of them. And that's why a comprehensive approach like what we're doing, where we could pull in all the data off a big footprint, we can then start to track down people and get them treated. So that's part of the solution. The other thing is how few people are actually tested for it. So we've got testing programs that go on, and there's all these sort of targeted testing programs, prison health, the A&E assumed consent approach where they're testing for Hep B in A&E departments and so on. That's fine, but there's a whole load of other people who've got an abnormal liver function test and have never been near a viral hepatitis test, and that's another big chunk that fairly straightforward and without massive expense, these people we can get them tested and we can start to find them. So those are the challenges, I think, for the viral hepatitis. I don't think it's quite as easy as we think of just, here's a list of the remaining people to treat them all, and then we'll have eliminated the disease. I think it's going to be more difficult than that.
So what I hear you saying about viral hepatitis, let me just see if I got you right. First of all, they have to want to be found or be willing to be found. And then second of all, once they're found, we have to have done tests that actually identify the scope and scale of the problem.
Yeah. And then we have to engage them in care, because some of those are really difficult to engage in care.
So dealing with the younger MASLD patients, the second issue would still obtain, but it would probably be easier to get them into the system. And once you identify the disease earlier, easier to enroll them in care. Is that kind of what I'm hearing?
Yeah. So the challenge is for that group, because it's a growing group, the numbers are big, we need to get good at risk stratification. So not everybody with a small amount of excess fat in their liver needs some urgent intervention, drugs and so on. And just a generally more healthy lifestyle is all we need to do. So what the challenge there is, because if we're going to target treatment, whether it's lifestyle treatment, whether it's drug treatment, whatever it is, there's a cost to the individual with side effects and so on. And then there's a cost to the system of huge numbers of people needing treated. So what we need to be really good at is risk stratifying and also predicting who's going to progress. So are there additional things? Yeah, things that we're looking at in some of our future research around, is genomics going to help? Is genomics going to help us predict, right, you've got a fatty liver, but you're in the safe group. You're going to be fine. The science isn't there yet for all of that, but it's coming, and that's going to be really important. So how do we predict which of that huge number of younger people, early signal of fatty liver, which ones are going to progress? If they've already got advanced fibrosis, yeah, we know they've progressed. We can get on and do what we need to do. But that's the challenge in my book.
Okay, so help me with one nuance and then back to Louise. Okay, the difference between risk stratification and predicting who's going to progress. It sounds to me, from a statistical point of view, like that's two ways of saying roughly the same thing, and I know it isn't, so please go ahead.
They definitely overlap. So risk stratification, in my mind, is where people are now, how far have they gone on that process. We don't have perfect biomarkers for this, but if you can distinguish inflammation and fibrosis, then we know that statistically, if you have a lot of inflammation but not much fibrosis yet, you're at risk of getting fibrosis in the future. So you're doing two different things there. You're saying, okay, let's risk stratify people from a where have they got to now point of view, as in these are the people who we need in care and being under surveillance if they've got cirrhosis or whatever it is. And then there's that, okay, what's your future risk looking like? I guess a different form of risk stratification, and it's that goes into a predictive model. So clearly those two groups overlap because it depends what time point you're looking at. And you'll see people who have already progressed. That's how we need to use the data as best we can. And as I said, the more data we have, the more data points on an individual, the more likely we are to get that right.
Absolutely. You've got two different areas there, but I think on the hepatitis C perspective, I think it depends on your local area. When we were treating it in Imperial, 62% of everybody we treated was born abroad. They didn't catch their viral hepatitis through injecting drug use. And I think it depends what cohort we consider. And the majority of the people born abroad were born abroad a long time ago. So we're talking about an aging population. We also have the largest Egyptian and Arabic population in the UK sitting in central London. So again, we had different risk factors for viral hepatitis. So doing something like hepatoscope within that population area would pick up a lot of the older patients who can now just go on all orals and be cleared, because we know that's where our biggest infected population sits, not necessarily the ones who are the newest acquirers of hepatitis C. For me, that would have a different scope. But on that point, have you used hepatoscope within a hospital, a big NHS acute trust environment, for example? We know that we generate millions of blood tests. We know that the majority of people who see an abnormal liver function test in a hospital who aren't in hepatology will say they've probably on antibiotics, they've probably this, they've probably got an infection. So they're absolutely ignored. It's been raised here before, and I can't remember, Roger, who raised it, but we also know that John Dillon says that only 5% of abnormal liver function tests are actually responded to. So we know that people don't respond to them. Have you tried it in a big NHS trust to look at patients who are currently or in the system and have been in there for a long time?
So we've got that data. We can distinguish between inpatient and outpatient data, non-admitted data, and so on, and primary care data. So the ability to do that search in the system is there. Interestingly, I think we want to do better because we've got 11% were investigated for our overall global cohort. So it's better than in TASAR, where it's 5%.
Get in! 89% missed.
Yeah, it's not really something to celebrate. Yeah. So I definitely recognize that as a problem. What I also think is that it's potentially the right response in an acute illness, because there's so many things that make your liver function test go a little awry for a period of time. When I look at this with, when I'm doing inpatient care, I think that general understanding probably isn't there that, okay, this looks like it's all part of the acute, but let's just make sure they're followed up 3 months down the line. If this is all acute, this will have gone back to normal. So does that step happen? Probably not as often as it should. And then if it is still abnormal, well, then we know that a lot of them don't get that follow-up. We need to be careful, though, because when people are acutely ill, two things going on, isn't there? They've got a higher priority illness than any chronic liver disease is going to progress over decades. So the priority illness needs to be dealt with. And there's a potential for overdiagnosis at that point in time. So that's why I think sometimes, just taking a retrospective look, filtering out all the inpatient blood tests and say, is the signal still there, will help us. And we can do that with a hepatocyte.
So you bring that over to the States, right? Where a couple of things are different. First of all, we now have a drug. Second of all, we have health system records. Third, we don't have the ability to create the kind of discipline that you do over there because data records aren't nearly as centralized. Even if someone like me spends their entire life in a single major health system, which I do, then I'm pretty easy. If not, then even if the systems are integrated, pulling all the data together might be complicated. I have a good friend who's basically in the same health system I am, but is being treated for cancer right now in a different health system. So somehow they've got to keep all those records integrated. That's obviously a different kind of case because we know what they're looking for. But I'm wondering where or how tackling this issue might be different in a place where you have a drug that's currently available, but start with you have a drug that's currently available. Does that change anything except for the fact that you can motivate people to come in more readily once you identify them because you've got something they understand that you can do for them that isn't just eat better, work out more?
Yeah, definitely around motivation. Also around motivating clinicians. Historically, we've lived through an era of quite a lot of nihilism about fatty liver. Okay, it's just one of those things, but it's because they've got diabetes and that's it. And there's no treatments anyway. So as soon as you get to no treatments anyway, you're turning off a lot of people's interest. So yes, when there are treatments, you're going to get people much more enthusiastic about let's get these people in for care. So that's where I think it makes a difference. I think the second thing is that comes with cost. And so we need to be using all treatments appropriately and targeting the right group of patients. Whether it's a big group or a small group, it needs to be the right group. So you need to use all the information you can to make sure that you're getting approved therapies to the right group of people. That's something where it's really helpful to have a systematic way that's kind of easy for the clinicians to use. And that's where we started out. We want something that's really easy for people to use so they can actually use it in everyday practice. It's powerful technology, but it's also reliable and fairly straightforward. And doctors tend to get ground down by complicated IT systems and much more will engage with easy to use systems. In terms of the data side of it, it's what it is. So to make this approach effective, you need to be able to identify the same person reliably if you're going across multiple different systems. If you can do that, most of the other battles are won now. Okay, you've got data governance, but assuming you can get past that. And the way we serve data back to clinical teams only who have a legitimate relationship with the patient means that side of things works. So you need to be able to identify reliably who that patient is, and that varies depending on where you're implementing the system. But the system is also designed to have a very simple ingestion of data. So you not like building a big secure data environment for research purposes where you have thousands and thousands of interrelated and complex tables of data. We need a table of data of blood tests. That's it. It's a few fields for each test. As long as we reliably identify who the patient is, when they had the test, where they had the test, and what the result was, the rest kind of falls into place. And that's a relatively straightforward solution. So when people talk about interoperability of systems and transferring large amounts of healthcare data between systems and making one EHR recognize another set of EHR data, that's much, much more complicated and therefore challenging and expensive to do. We don't need to do that. We need relatively simple import of data and then match it to the right patient, and then you're away. And if you've got enough data, you're going to get a signal anyway in one system.
And the we you're talking about here is your system. It's not a national comment. It's not a comment about US versus UK. It's a comment about for the things that you're doing, what you need is a lot less than the complexity that could be created. Do I understand that correctly?
Yeah. So that means, okay, there are some certain advantages in the UK about the NHS number. There are certain disadvantages around governance and GDPR. So take the approach that we've successfully done in the UK to the US. There's slightly different problems to solve, but I think they're all solvable.
I may have said this last time you're on also, but I'm kind of a systems theory person. And one of the things I've always believed is that complexity is easy and complication is the enemy. And I think I just heard you say that.
I'm glad I said that.
And that the data that you need isn't complicated. The data you need is fairly straightforward if you can get it sequentially. And in fact, grabbing more data in more complex formats and interoperability and all that simply creates challenges that you might not need. That was what you said that I translated.
It doesn't solve the problem that we are setting it. That's a really good translation. And it's what we set out right at the beginning to solve that problem. Keep it really simple, what we need to import.
So how do you get somebody to implement a solution that is simpler than the one they think they have to implement? Do you have a problem getting somebody to understand that this is a simpler problem than you thought it was?
That's a problem in healthcare generally. It can be simple.
Yeah.
But we think it's complicated. Let's make it simple.
I'm processing how different people I know that are part of this audience are going to respond to it. And some of them say, that's too easy. It can't be that simple. And my immediate reaction is, well, yeah, it probably is that simple. At least the first 85% of it's that simple. And right now, as you point out, we're identifying 5%, 11%. Heck, let's get it up to 60 or 70, and then we can start to worry about the complexity and what's left. How easy or hard is it to explain to people that this is a simpler solution than they thought it was? And which groups of people do you have an easier versus a harder time explaining that to?
So I try to avoid explaining it, and I try to show people. That's the first thing. If you show people what it does and how it works, people get it really quickly. So I've done quite a lot of presentations to like-minded in similar way clinicians, whether they are pure hepatologists or a wider interest in population health. And I said, I spent 5 minutes trying to explain it. Let me just show you what it does. And they, oh, right. Okay, I get it now. That really does work. So getting innovation uptake is challenging in health systems for whatever reasons, and lots of people have written endlessly on why it's really difficult. But I think that first step is showing people it actually works, and it is a relatively intuitive way of looking at a complex problem. So that kind of really gets the conversation going, and it helps people understand. Kind of raises the question then. People say, well, why has nobody else done it if it's that easy? And it wasn't quite as easy as that to build, to be honest, but once you built it, it's great. And being focused on a real goal of creating a simple system that's simple to use and simple to implement and vary the complexity and the cogs and the machinery inside is what the approach we've taken. So,
well, yeah, because simple and easy aren't the same thing, right?
No, there are a number of quite challenging things to understand along the way that we finally cracked. That's why it is. And I think the world is a bit hung up, though, on these big data solutions to stuff, and big data can get very complex very quickly.
I would say very complicated very quickly.
It's very complicated and it gets very expensive very quickly.
Yeah.
And in fact, it doesn't need to be if you're focused on what we need to do. And just to illustrate the kind of problem-solving side of it, we had a great data analyst working with us around the cumulative liver damage kind of markers of that, trying to make sense of our initial data set. And it took them about 6 months. And then now the system will do that in 6 seconds. And that's actually a fib because it's about less than 1 second, but I don't think it's quite 0.6 seconds yet. So it's taking something that's actually really difficult to do, if you start with a raw material, and just creating a way of just processing that raw material into some way that it can be used. And then all the clinical use cases just drop out of that because they are then putting that data in the hands of clinicians.
And I think, Roger, when you were saying at the beginning about that, why is it so simple? It's because, like anything, people put a lot of time and effort and complicated problems to make it as simple as possible, to make it engaging to patients, easy to use within healthcare. It took me 12 years to develop a FibroScan service through the NHS. And yes, it was the largest one running at the time, but we've condensed all of that skill to make what we do now very simple. So you can have a plug and play that goes tomorrow. And what we do, obviously, we collaborate, and by collaborating in the future is locating these patients is one thing. If you hand them out to the GP, the next bit is, what am I going to do with these? How am I going to do that? So if you put the second stream sequential testing in, like the algorithms, you find them, you FibroScan them, you hand them to the right area, or you use another diagnostic. Making that package as simple as possible brings in lots of complicated and hard work for years to be able to do that. We do need to make liver care simple because there is so many people in need of liver care, whether or not it's just poor liver health or liver disease that is going to hit us in transplant lists. Australia couldn't possibly keep up the new rate of referral that we predict or we have seen in the US for postmenopausal women driving transplant need. We don't have their organ donation. The UK can't do that. So we do have to look at all of these. Absolutely, you've got the fastest growing female population for transplantation. So I think we need to make solutions very simple. And this is a beautiful system that can plug and play. People can use clinical trials. You can pick out your higher risk populations. Obviously, it can be used within hospitals and the demographic. And what Tim's described tonight excites me even more. The potential, I suppose, Tim, could be to utilise all of those patients who've had normal liver function tests over the years, who've then been found to have late-stage disease. Could you retrospectively use it to see if there was any signal that could be picked up in all of that population backwards? Because they're the ones who we cannot find now until very late.
And so that's where there's some fascinating research, I think, coming down the line, which will go way beyond any ability of maths and that I have and statistics and artificial intelligence and all those things. But the principle is absolutely right. You've got a huge and growing historic data. So we're doing more blood tests every year, and there seems to be no change in that trend. So the raw material is getting richer and richer as time goes on. As an example, finding patients with hemochromatosis with this is actually quite challenging because there's so many other drivers of abnormal iron studies and the like. But I'm pretty certain that we will be able to use artificial intelligence layer or some other layer over the top to look at that. And the same, if you have people coming in with advanced liver disease and we're actually looking at that, how can we predict people who are going to be in hospital in the next 18 months? Yeah. And some of those, it's quite subtle, but there are definite changes. And if we can do that, then the case for implementation suddenly got a whole lot stronger. Because, if we can just find people, if you're going to say they're coming in the next 6 weeks, that doesn't really help, particularly. It's a bit late. If it's, and the healthcare systems are not designed for long-term investment around, I'm going to save money in 15, 20 years with this. Yeah. But if the more we demonstrate, actually, this is becoming an urgent problem, but there's still time to act, that window is really important.
So the sweet spot is 18 months plus minus 6 months? Is that kind of thing you're talking about? A year to two?
Yeah. And that's great. And I think we've already demonstrated with the data we presented in DDW was around actually, that it's there. We need to refine it a little bit, but it really is there. And that's why also the more people that use this system, the better, because we'll have lots of other people looking at it in slightly different ways and trying to solve the problems. And somebody's going to come up with much better ideas than I have so far. So that'd be fantastic. The more people do that, the quicker we're going to get to those answers.
Last question from me, just picking up on your point. Comorbid connection. Are you able to analyse the data and see the percentage of diabetes and heart disease within that? I believe asking the question of screening for liver health to protect and locate 1 in 3 adults that have bigger problems and metabolic disease is probably a more cost-effective argument than saying just looking for liver disease, less than 2% of them will cause mortality. Are you able to look at the strength of who you've pulled out and how their comorbidities could have been prevented and protected, and also that how many really percentage have those?
So yes, we're running those searches obviously because we're looking for people with steatotic liver disease. So your HbA1c and other biomarkers are really critical, and the numbers are astonishing. So they're really big, which means, of course, we then need to come back to that. Let's target the right people, but the numbers are big. I think that's part of it. I think absolutely we've got active discussions about layering some additional research on top of this particularly for cardiometabolic. Can we predict who's going to have a high coronary calcium, CT calcium score using the existing biomarkers? Because to be honest, having a bit of chest pain isn't a very good predictor one way or the other. Lots of people have chest pain and have completely normal coronary arteries. So can we predict from all this data who's got that abnormality? This is straying way outside what I do. I'm not a heart doctor, I'm a liver doctor, but the same principle applies. And I think incorporating some additional data sets into that, if they're good factual data sets, will help us as well. So why not pull in some primary care blood pressures, for example? That would create some really interesting insights.
Okay, we're ways into this discussion, which has been fantastic. I'm going to ask each of the three of us to do something really hard, which is come up with a 1-sentence summary of something the listeners should take away from this. And I'll go last. Louise, you might want to go first because Tim probably has a broader field to play from than either of us.
Well, I'm going to defer to one of our previous surfers, the wonderful Stephen Harrison, and keep it simple, stupid, because simple can work, but simple is often the most complicated thing you've ever come across in a nice small package. So keeping it simple, let somebody else do the work and give you simple.
Okay.
Because it's really going to get us the best trial patients and the best patients to treat.
Okay. Tim, 1 sentence.
We can now really simply use the data that's stored in our systems to identify patients for further trials, for further research, for treatment, and start to impact on that tsunami is the right word, of liver disease. But I think the takeaway is an urgency. There is a real urgency to do this and to do this today rather than wait. And I guess my question is, what would we be waiting for? Let's crack on and do it.
Okay, so then mine, which kind of follows in from that, I think pretty neatly, is that properly applied, sequential use of available data can solve a lot more of this problem than people believe. That's good. I'll be back in a minute with a question. For those who haven't figured it out, you can see roughly where the question of the week on this is going to go. I'll be back with that in a business report in a couple of minutes. Tim, always a pleasure. Louise, good luck Liverpool on Thursday in the Europa and over the weekend. And we will be back next week.
Thank you.
Everybody say goodbye.
Goodbye, everybody.
Bye. Thank you very much, Roger. Thanks.
Thanks for joining, Tim. Bye-bye.
And now, here's Roger with this week's question of the week.
And here's our question of the week. Listening to Tim Jobson discuss the extensive back-end work needed to make simple, inexpensive, readily available data work as the foundation for identifying patients we need to get into treatment, I'm mindful of the old Dolly Parton line, "It takes a lot of money to look this cheap." With that as background, this week's question is, what contributions can you and your organization make to support using repeat measures of readily available data to identify patients who are targets either for treatment or clinical trials, depending upon the work you do?
And now for the Season 5, Episode 10 Business Report.
Slava Ukraini, glory to Ukraine, and also Am Yisrael Chai, the people of Israel live. I find the more weeks I start with this topic, the more likely I am to get into partisan U.S. politics. For this week at least, I want to change that. Instead, I simply want to serve witness to the courage and resoluteness of the Ukrainian people in the face of what is now over 2 years of unjust bombardment from the Russians. I want to serve as witness to the horrible loss that families of the Israeli hostages feel as this occupation passes its half-year mark, and the unspeakable tragedy that is life in Gaza today. Our politicians have the ability to move solutions forward on all these issues. Let's hope they do so. And let's send healing thoughts to everybody who needs to heal in the Ukraine and Israel and Gaza. Heroyam Slava, glory to the heroes, and also Am Yisrael Chai, the people of Israel live.
Our marketing campaign is rolling out soon.
As I mentioned last week, we have acquired research demonstrating that we have far greater audience reach than simple IAB numbers suggest. With over 3,300 followers through the major podcast sites, close to 1,000 LinkedIn followers, and more in several other places. We're putting the finishing touches on our marketing list and our story, so expect to hear from Steve Ennin or me soon.
Roger's point is especially true if you want to share how having Resdifra approved increases the value of your products or services.
On that point, we've been contacted in the last week by past sponsors and friends of the podcast who believe that MASH Tsunami might be a valuable vehicle for exploring how the value of their products and services are growing now that Resdifra is available in the U.S. and treatment is about to pick up. If the same is true for you, let's talk about how MASH Tsunami can help get your story out to our audience.
Thank you, France, Denmark, and South Korea.
We have other countries to thank as well, but France, Denmark, and South Korea all have put us in the health and wellness top 250 for multiple consecutive days over the last week. Keep telling your friends that we're back and better than ever, wherever you live, and we'll thank your country too.
This week's vault comes from Tim Jobson's last Surfing MASH appearance.
As I mentioned at the beginning of today's episode, this is the second time we've had Tim Jobson on. He was also on in January of 2023 talking about his basic service. Our Vault conversation talks about how they do a lot of the basic computation work they do and what the major steps are that are involved. It will serve as a foundation to understand what he's talking about today when he talks about ease and difficulty of getting at different kinds of data and the things he can do with them. I loved this conversation last year. I love it now. Enjoy. So that's it for this week. I want to thank our team, Jorn, Louise, Mike, Eric, Steve, as we keep moving forward. Enjoy our upcoming conversation Saturday and Sunday. Please take a listen to our question of the week and, of course, reply. We'll be back next week. Until then, stay safe, surf on. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.